morning, everybody. And again, happy Halloween. And I hope everybody has a great and enjoyable and restful weekend because we all need it after everything we are going through. But I do feel some calm and a little bit of a reduction in the stress on us from COVID. So thank you for every opportunity I get to say thank you to everybody and the amazing work that you're doing out on the front line. So always grateful for that work. Fascinating topic today, something I have a strong passion, and I can't wait to challenge our speakers on the panel discussion as they talk about managing patients at elevated risk for breast cancer. So our speakers today, let me just pull up we have Dr. Robinson, who is a hematologist oncologist at Virginia Mason, clinical associate professor in the Department of Hematology at the University of Washington. Dr. Robinson received her MD from McGill in her hometown of Montreal, so she's a Canadian. She completed her internal medicine residency at Indiana University and her fellowship in hematology oncology at UW. Dr. Lee is a fellowship-trained breast surgeon who went to medical school at Pacific Northwest University of Health Sciences. She completed her residency in general surgery at Henry Ford in Michigan and completed her fellowship in breast surgery from the University of Southern California. Dr. Eby is I think Dr. Eby, he told me, is the chief of breast imaging at Virginia Mason Medical Center. He received his MD from Vanderbilt, completed his residency in diagnostic radiology and a fellowship in emergency radiology and breast imaging at the University of Washington. So I think our first speaker, am I right, is Dr. Robinson. Am I right on that, Gary?
No, it's backwards. Dr. Eby, Dr. Lee, and then Dr. Robinson.
All right, so Dr. Eby is up first. Thank you, Dr. Eby, and take it away.
Thank you so much. It's really my pleasure to be here today. And as we finish off October, this is actually the 29th, the end of Breast Cancer Awareness Month. I had the pleasure of kicking off October when Breast Cancer Awareness Month, also with Dr. Lee and Dr. Robinson, October 1st with the Virginia Mason Grand Rounds. We have no relevant financial or other relationships to disclose. And we're going to have a case-based discussion today where I'm going to review the latest guidelines for screening. I'll talk about the radiology piece. Then Dr. Lee will follow talking about the surgical management of patients at elevated risk. And finally, Dr. Robinson will finish off with the medical management of patients at elevated risk for breast cancer. So as you probably know, this is a very common disease. Almost 13% of women will be diagnosed during their lifetime in the United States, and we expect about 285,000 new cases in this calendar year with 43,000 deaths. And as we continue to treat this better and better, we have more and more survivors. So continued management of patients at elevated risk throughout their lifetime is a major aspect of the care that we continue to provide, with over 3.6 million women living with a previous history of breast cancer. Now, breast cancer at Virginia Mason mirrors the actual age distribution of breast cancer throughout this country. I like to show this slide because I think it's important just to understand the bell curve. Certainly, breast cancer becomes more common as women age, with a peak in the 60 to 69 year decade. But I like to make sure that people understand that 18% of the new cases of breast cancer are diagnosed in women in their 40s. This is also a disease of women in young, very productive parts of their life. And it's important that we recognize that when we talk a little bit about when and how to screen. So we're going to talk as a case-based discussion about a hypothetical patient who's about 43 years old, who's premenopausal with no family history, no personal history, no other known risk factors. And the question that often comes up is, should I get a mammogram, and when and how often? And there's been a lot of debate within the popular press and also within medical experts about when to start. But the benefits of screening, when considering whether or not to get it, include a significant decrease in the overall mortality rate. So specifically, taking patients who have a diagnosis of breast cancer and treating them so that they don't die from breast cancer, they die from something else many, many years later. We know that annual screening starting at 40 is going to save the most lives, but it also impacts the treatment. Patients who are screened tend to have smaller cancers, their surgeries tend to be easier, their cosmetic result tends to be better. We tend to use less chemotherapy and less radiation therapy. So treatment is easier for them, it's less expensive, and it gets them back to their normal lives faster. So these are the important benefits of screening. And in fact, the United States Preventive Services Task Force agreed with a bunch of other medical societies that screening starting at 40 has a significant impact, and doing it annually will save the most lives. And these are the recommendations from, for example, the NCCN, the American Society of Breast Surgeons, and the American College of Radiology. And we should consider continuing screening as long as a woman is in good health. So in this discussion with our patient who's in her 40s, we would recommend a screening. And in fact, she went and got a screening, and these are the images. A screening mammogram consists of 4 views. We got 2 craniocaudal views and 2 MLO views, so 4 views total. And about 90% of the time when women have screening, they will simply be told that everything is fine, and it's a reassurance that they've taken a proactive measure to care about themselves and their health, and nothing else needs to be done. But in about 10% of cases, we'll ask them to come back so that we can check something with additional mammogram views or perhaps an ultrasound. And even the vast majority of those will be reassured at the end of their visit. In our case, we asked our patient to come back because she had some calcifications in her left breast. And we brought her in for additional views. This is called a diagnostic mammogram. Took a look at those calcifications here, and we recommended a biopsy for those. And this happens in about 20 out of 1,000 patients. If we screen 1,000 patients, we're going to recommend a biopsy for about 20. So it's a small percentage, but it's an important thing to do so that we can discover cancer early if it is in fact there. Now, she had her biopsy and it was not cancer, but what we detected was something called atypical ductal hyperplasia. Now, this is a tissue change that in some patients indicates an increased lifetime risk, or in some patients, sometimes there's cancer nearby. So we're not done necessarily with her. Now, as I mentioned, this ADH entity indicates a potentially elevated risk for her lifetime. And these are the radiological recommendations for additional or supplemental screening for patients who have an elevated risk. And they're broken down into different categories. So the highest risk category are those with gene mutations. They should start mammograms at 30 and perhaps an MRI at 25 to 30. There are also patients who've been treated with chest radiation for other malignancies at a very young age, usually before the age of 25. They should also consider mammogram and MRI to start fairly early. Then we have patients who had premenopausal breast cancer or a personal history of breast cancer and dense breast tissue. They should also perhaps be getting MRI at the time of diagnosis. And then our patient who has had now a biopsy confirmed atypia or atypical ductal hyperplasia should also consider MRI. So we have this discussion with this patient about what else she needs to do. And there's one more thing that we have to discuss or consider in her particular case because she's Black. In the United States, there is a persistently elevated death rate amongst Black women from breast cancer. This is the red line on this graph. This is taken from SEER data. You can see that death rate is decreasing, but it remains higher than white women, which represents the blue line. The gap has not closed. And over on the other side, what we see is the incidence of cancer in Black women. It's also rising over the years, and it is now equal to that of white women. So same incidence, but significantly higher death rates among Black women. And nationwide, what we see is that Black women get breast cancer earlier, 4 years younger, they die younger, they more often have triple negative, very aggressive cancers, and those are less often ER positive. And overall, they are 42% more likely to die from breast cancer. This is an important disparity that we really need to address and be cognizant of, not just with our patient, but with all Black women. At Virginia Mason, we find the same thing when we look at our own data. Younger age at diagnosis, younger age at death, more triple negative aggressive cancers, fewer ER positive. So our experience reflects the national demographics. And what we also see is that the reason, or part of the reason, may be because there are more genetic mutations among the Black population, which again tend to lead to aggressive cancers at a younger age. So with this in mind, there are additional recommendations for women who are at elevated risk, especially Black women, to get a risk assessment before age 30. And this means a discussion with their doctor or a genetic counselor who can take a family history and determine if there are any indications that she might be harboring a genetic mutation, or that screening needs to start even earlier than age 40, or if we need to add another imaging test such as MRI or ultrasound to catch any cancer that she has very early. So with that in mind, and with the diagnosis of ADH, we referred her to our surgeon. So I'm happy to introduce Dr. Lee, who is here with us at Virginia Mason. We're thrilled to have her, and she's going to talk about the surgical management of patients at elevated risk for breast cancer.
Okay, so once I see this patient, I've already known that she has the diagnosis of atypical ductal hyperplasia. I'm going to go over these risks with her too. So there are more factors besides what Dr. Evie had mentioned that puts a patient at high risk for developing breast cancer. So female gender, increasing age, family history, genetic mutation. In our case, this patient has atypical breast biopsy, history of chest radiation, early menarche, late menopause, nulliparity, delayed childbearing, postmenopausal weight gain, alcohol consumption, dietary fat, and then sedentary lifestyle. So the ones I listed on the right side, these we can control, some of them harder than the other, but we can control those. As far as like how much each of these contribute, so you can see here, these are the relative risks. So some of them are higher than the other. The ones I've highlighted in red are those that have a higher relative risk. And then the highest one is the extreme breast density. So as far as like these risk factors that we've identified in these women, how do we actually measure an individual's risk of developing breast cancer? So we have these risk models that we typically use. So the Gale model and the Klaus, these two, have been used more often. However, there is no gene mutation estimation. Now, the bottom three, they do include the gene mutation estimation. And the one that I use most often is the Tyler-Cuzick or the IBIS. This is easily done. You can do this online. They're all free, but it takes time. And I think that's why a lot of people don't do them. So when I was in training at Henry Ford, we used something called the Hughes riskApp, which I find to be very useful and very convenient. So what it does is it takes all 5 of these risk models and it transfers it to one app on an iPad. And so we would give these patients who are getting their screening mammograms this iPad as they're waiting. It's about 10 minutes and they answer all these questions. And once they do that, we get this genetic tree, but we also get the risk of breast cancer, ovarian cancer, and then also colon cancer. This is then uploaded onto their chart and it makes the conversation much easier. And then we're able to identify who else needs to, get an MRI, get a conversation with breast surgeons. So we actually ended up doing a study and we wanted to identify high risk for developing breast cancer. And like Dr. Evie said, African Americans are more likely to die from breast cancer than white. And so we wanted to compare these populations to see if, because, African Americans are more likely to die, are they at higher risk? And we didn't find that. We found that white Americans are still at higher risk for developing breast cancer. But I think what's important about this study is that we identified 13.7% of women who are at high risk. And so in the literature, we're expecting to find 4 to 5%, but we were able to capture 13.7% of women who are at high risk, and they didn't even know they're at high risk. And I think this is important because it shows you that it's important to get screening early and so that we can detect these women. So with that, we'll go back to our patient who's 43, premenopause. She's got calcifications on her mammogram, and she had a needle biopsy showing atypical ductal hyperplasia. So I talked to her about that. and now we talk about her actual lesion. So what does this mean? It's not black and white at all, and it's actually very gray, because as you can see in the literature, the upgrade rate of DCIS or invasive cancer from a core needle biopsy of these high-risk lesions, it's variable. So in our patient with ADH, in the literature, you'll see that there's an upgrade rate of anywhere from 0 to 62% with a mean of 23. Other high-risk lesions here are atypical lobular hyperplasia. Again, you can see 0 to 67% upgrade, flat epithelial atypia, 0 to 21%, lobular carcinoma in situ, anywhere from 0 to 60%, and papillary lesions, 5 to 20%, and then a radial scar, anywhere from 0 to 16%. So I think it's safe to say that with any of these lesions, I would want to see the patient as a breast surgeon to have a discussion with them. And the recommendation right now is to excise this because of the upgrade rate. We don't know if there's cancer or DCIS in there. And so there's another study that I did at USC, and we looked to see which high-risk lesions do we need to excise and which ones can be watched safely. So what we did was we took all the patients who had a core needle biopsy, so their pathology is on the vertical axis, and then we compared it to their surgical pathology, so that's on the horizontal axis. Now, if the core needle biopsy pathology was the same as the surgical pathology, that's shown here in yellow down the center. If the surgical pathology was better than the core needle biopsy, that's in green. But if it's worse off, then that's in the red to the left of the yellow line. So what we cared about were the upgrade to invasive cancer, DCIS, either grade 1, 2, or 3, because all these would need to be excised. And so in our patient who has ADH, her risk of being upgraded to cancer is 26.2%. So I use this chart quite often to show patients that, you know, this is much too high and that I would not accept this. And the next step we would need to do is to excise. So for this patient, I would recommend a wire-directed excisional biopsy. And so when we did that, there were no malignancy, which is great. And so the next step in this would be, I would recommend her to go see a medical oncologist to discuss further risk management. So with that, I will stop sharing and let Dr. Robinson take over.
So patients come to me when we want to consider the option of medication to prevent breast cancer. So this is the question: should our patient take medication to prevent breast cancer? So the U.S. Preventive Task Force says yes, and has said so since 2013, initially for tamoxifen and raloxifene, and then more recently adding aromatase inhibitors as well. And this applies to women aged 35 or older who are at increased risk of disease and low risk of side effects. So why would we do it? It cuts your risk of developing breast cancer. And not only that, when you cut the risk of developing it, even though it doesn't improve survival, you decrease medical, physical, psychosocial, and financial costs of breast cancer treatment. The treatment is fairly short compared to what would happen if you took medication to prevent cardiovascular disease, and it's lasting. If you have side effects, they stop when you stop the drug, and it's incredibly inexpensive. So what's the problem? So it turns out about 15% of women are eligible for this medication, but less than 10% of women actually take the medications. So why is that? There are a number of barriers for the prescriber. One is there's limited opportunity to do breast cancer risk assessment in busy primary care practices. There's discomfort in prescribing medications used for cancer, and therefore some lack of familiarity with the drugs. And there's a perception that it's really not worth it. So first thing is, how are we going to help prescribers figure out who these patients are? Dr. Lee talked about one method. And when we prepared the Grand Rounds lecture we gave a month ago at Virginia Mason, we looked into our current system, in which it's kind of ad hoc. We find out some demographics, we have some personal and family history, we collect breast density, but it's not included in a risk model. And then once patients are identified, we don't have a clean pathway to get them to physicians. We do have a breast clinic nurse practitioner, or two of our medical oncologists, myself and my colleague, who will talk to patients about this. And we have a backlog in genetic counseling appointments. So this led us to develop a future state that we'd like to imagine, where in fact, for example, like Dr. Lee talked about, patients could input their data when they come for their mammogram that could be integrated with their mammography result, and that we could have a pathway ready for patients. And also taking into account that some patients want screening more or less often, and that this could be incorporated into our electronic medical records. So the next issue is learning about the meds. So we have tamoxifen and we have raloxifene. These are in the same class, and they are essentially estrogen receptor blockers in the breast, but they act like estrogen in other tissues. Tamoxifen has been available for this purpose, approved by the FDA in 1998, 20 milligrams a day for 5 years, cuts the risk of breast cancer in half, and if you have ADH, cuts it by 86%. And as I said, this is a durable benefit. There are side effects, absolutely, but they're mainly in postmenopausal women, double the cases of uterine cancer, though still rare, and an increased risk of venous thromboembolic disease. This can often be managed. It's usually in association with other risk factors such as travel, long car rides, hip and knee replacements, and other such high-risk events. Raloxifene was developed to be less risky, and there's a less risk of uterus cancer, but it's also slightly less effective. And this is only for postmenopausal women. So the newer drugs, aromatase inhibitors, they're only for postmenopausal women, and they decrease estrogen production in the abdominal fat and adrenal glands, which is the source of estrogen in these women. There's no increased risk of cancer or VTE. There is, however, an increased rate of bone loss, but no increased rate of fracture. So patients and physicians worry about side effects. In this study, the anastrozole, one of the aromatase inhibitors, was compared to placebo, and there were increased risk of side effects, but not much. The adherence rate was pretty similar for both the placebo and the anastrozole, and these side effects can be managed most of the time. So there is a new option, and that's part of the reason I wanted to give this talk, which is low-dose tamoxifen. This was published 3 years ago, presented at the San Antonio Breast Cancer Conference, and this is a 5 milligram per day dose for only 3 years. And this was a study of 500 women. It had the same 50% reduction in breast cancer. And it didn't take many patients before you saw benefit. The number needed to treat was 22 women. In terms of side effects, there was one endometrial cancer in the treatment group. There was no difference in venous thromboembolic disease. There was a mild increased risk of hot flashes and endometrial thickness without polyps, but no change in a painful intercourse, vaginal dryness, or arthralgias. So unfortunately, again, only 2/3 of the patients did complete the course. So let's say we're going to give patients this medication. As physicians, what do we think about? Well, how long are they going to live to make it worth it? Have they had prior blood clots? Do they have fatty liver disease? Because tamoxifen can worsen this. If they had a prior hysterectomy, then there's less of a concern about uterine cancer. If they have osteoporosis, tamoxifen can help. That may be an argument to avoid an aromatase inhibitor. And it turns out tamoxifen can reduce migraines. So back to our patient. So she's 43, so we don't have to worry about certain issues. She's premenopausal, she has ADH. Her lifetime risk is greater than 20%, and in fact, maybe up to 30%. So what are the things she might be worried about? First of all, we often have used the term chemoprevention, which is actually a terrible way to get somebody to take any medication. Patients are worried about cancer and blood clots. They're afraid of menopausal symptoms, and they can read all kinds of things on the internet that are in fact incorrect. So if we look at the average patient, we would say that, the average high-risk patient, there's a 20% risk of cancer. Tamoxifen will cut that in half. For this patient, however, she has a 30% risk, and tamoxifen will cut her risk to only 4%. And I think that's a very compelling visual. When you talk to patients, the other thing that's really important is collaborative decision-making and figuring out, how motivated they are and what their worries are. Are they worried of developing cancer or dying of it? Are they having terrible menopausal symptoms? Do they know people who had breast cancer and died from it? Do they know people who took the drugs? Sometimes it helps if they have friends who've taken the drugs and are doing fine. Some patients always see themselves as in the 1% and are more motivated to take the drugs. And there's been research that shows that if you look at the medication bottle and think, oh, this is going to help me, as opposed to this looks like chemo, you're more or less likely to take the medication. So finally, tips I've learned along the way is that this is reminding the patients this is a low-cost medication. It's completely optional. They could try it for 1 to 3 months. And if they think they're having side effects, you can stop, see if the side effect they think is from the drug gets better, and then restart it to determine if it's in fact the medication. Patients like the idea of being told they can try the medication at certain dose and then drop it in half or a quarter, or even start at that quarter dose. We don't have 5 milligram tablets of tamoxifen yet, but you can take 10 milligrams every other day. And we work with them to manage their side effects. So overall, I do think we need to make this an easier option for physicians to prescribe and for patients to take. And I think we can make a difference in our patients' lives. Thank you.
That was excellent. Wow. All right. What a tour de force that was. And you did it all within within the half hour. So congratulations. So I look at this as a tremendous amount of information that you just put out there, and it covers a lot of different subjects, many of which there are controversies. We could probably take, breast cancer screening with mammography and, age of starting. We could probably have a lot of discussions around that, right? The whole risk assessment and how do we do that in our patients is a whole big discussion and not much a controversy. And then the management of ADH, and then of course the use of chemo prevention. Each of these are major topics. So thank you for covering them so thoroughly, so quickly. Gary and I are trying to create a platform for clinical standards. And all three of you are going to be tapped on the shoulder to help us with that as we think about your future state. Because I think your future state is, we'd like to know across CommonSpirit, how can we adopt best practices? All right, let me ask a question. And this is a general challenge. As a general internist, primary care provider, who is a McMaster EBM person, the controversy of overdiagnosis and overtreatment is one that you didn't all mention. And the downside of overscreening, particularly in that 40 to 50 age group. If any thoughts or comments about that, and maybe I would toss it over to Dr. Ebby if he has any thoughts about the dangers of overscreening. We often highlight the benefits of screening, but we don't highlight the downside.
Yeah, of course, this is a common discussion point, the discussion of overdiagnosis. I appreciate you bringing it up, and I'm happy to touch on it. I think there is overdiagnosis, right? There's overdiagnosis in every aspect of medicine, potentially. I think within the breast cancer world, what we need to acknowledge is that the overdiagnosis tends to really occur in patients who are probably in their 70s, who have very low-grade DCIS detected. DCIS is probably never going to present or never going to be detected and never impact their lives. And the good estimates, the best estimates, say that that's somewhere in the 10 to 15% range. Where we really need to
bring up a good point, though, that we need to be very clear. As you get older, above 70, the benefits of screening diminish dramatically, and it depends on the physiology. But let's put that aside. So so that's a whole nother conversation we could probably spend time on. But
yeah, I agree. I think what's also important, though, is to understand that overdiagnosis in women in their 40s is less than 1%, right? Mm-hmm. If the definition of overdiagnosis is that this cancer is never going to present and never become any type of clinical issue, a woman with invasive cancer in her 40s, eventually that's going to present. And we're better off detecting it in her 40s early than waiting for it to be a large palpable mass with axillary adenopathy or erupting from the skin, right? So I think the overdiagnosis discussion is important at the upper age limits, but it's not a realistic reason not to screen women in their 40s.
Dr. Lee, any thoughts? And also maybe I would throw at you that my understanding of some of the meta-analyses on ADH is that it's not as high risk as we all thought it was, depending on how you look at the data. But I guess and there was some meta-analyses I remember reading back in some journal club with residents. Any thoughts or comments on ADH as a risk? It sounds like the way you've broken it down, though, it's that table you showed is an amazing detailed table of the conversion rates by each strata. Is that new data?
Thank you. And so this study that we did was about a year ago, so it will be published soon so that everyone can have this table. But for me, how I explain like ADH or any of those lesions is it's like a piece of pie. So you do the core needle biopsy, and of those core needles, it shows that it's ADH. But what we're concerned about is like everything else around that. So the actual pie itself. So you're concerned that there's an upgrade rate with the tissue that you haven't biopsied. So the literature does show that there's a 0 to 62% chance of upgrade. So I mean, that's variable. Some studies will say it's low, others will say it's really high.
That's basically not help. I mean, 0 to 60 means could be anything. It's not
exactly.
Yeah, so it's it's an interesting area that needs, to me, further looking into, because when you say 0 to 60, to me that means we don't know.
Right. Right. So that's why we did our study, and it showed about 26%. And so to me, that's much too high. And I would remove that because there is a chance that there is cancer in there. So I think ADH is, one of the lesions where I would not just watch it. I mean, given this patient that was 43, now if somebody who's very unhealthy in their 90s or so, then we might have a discussion of, okay, do you want to watch it? Get mammogram in 6 months or so, that might be reasonable. But in someone who's young and healthy, my recommendation would be to excise it.
Gary, do you have any questions? Or are there any
questions? One question in the chat, but I have a question first. So a lot of the tables showed like, hey, if you have a genetic mutation, then obviously we move the screening curve to the right and we get more aggressive. But how do you know? How many people walk into you and say, gee, I'm BRCA positive, 1 or 2? So where does that come from? Or what's the recommendation for screening genetically in the first place?
So it's hard because not many people come in and know that they have a genetic mutation unless they've talked to their family members. But I think it comes from that screening way before, like the questionnaires that they get. And so we don't do that well because these questionnaires are long, they take a lot of time. And so I think that's why when we were able to have an app and have patients sit down and actually fill it out, we were able to capture not only those that are at high risk and those things that I've listed, but some were high risk enough that we send them to get genetic screening, to talk to a genetic counselor, and that's how they know.
Okay.
So I think that's still the challenge that we're trying to figure out. Like, how do we capture these patients that are, at high risk because of mutation? So it's hard to have that conversation.
And is there a coverage issue? I mean, I've seen payers go, hey, we're not paying for it. Or, well, if it's positive, we'll pay for it. But have you found that as an issue today?
Yes, definitely. I think the initial consultation is typically paid for, covered, but then it's when they run the genetic test. So they have to have, check off of X, Y, and Z for genetic tests to be run. But I think it's fairly cheap now that if patients want to pay out of pocket, they're able to. Now, cheap is relative. I'm not sure how much it is, but I think it's fairly inexpensive enough that some patients say, you know what, I'll just pay out of pocket for this. But I believe the initial consultation is free. And correct me if I'm wrong, Nanette.
There was a question in the chat about systemic racism. And I think the one thing that came to my mind in the conversation here about the disparities, there's the genetics that was discussed, but then there's access and cultural, all the elements and social, those structural issues. And when I was at Mount Sinai in Harlem, that was a big piece of the barrier research that we were doing in breast cancer screening, was really the socioeconomic barriers. So I don't know if Dr. Robinson or Dr. Webb, you have any comments on that.
One of the things that I think awareness is really important, that these are issues. And there's a lot of work in the breast cancer community, both from a imaging side and treatment side. One of the things Washington State did at one point is not only had it be that cervical cancer and breast cancer screening was free, but that any diagnosis made after such free screening was also going to be covered. This is less of a concern in our state, but I think we have to make sure, if we're going to screen patients, that we can in fact offer to pay for the treatments of the cancers that we find. So that's one thing that makes a difference. And culture, ambassadors in all communities are very, very important. In Seattle, Black women started a group called the Sierra Sisters, and they do a lot of advocacy in our city. But it's complicated.